All right. Well, thanks everybody for joining today. I'm really excited to be here with you to talk about neuromyelitis optica and cancer and to answer any of the questions that you have about these topics. So, before we get started, I just wanted to take a few minutes just to introduce myself. So, my name is Dr. Jacqueline Nicholas, and I'm a neurologist and neuroimmunologist, and I work in Columbus, Ohio. I work at Ohio Health Multiple Sclerosis Center, which is located right in Columbus, and at a large healthcare system. And my main hospital is Ohio Health Riverside Methodist Hospital. Um, and I just am incredibly excited to be here with you today because NMO, understanding and taking care of people with neuromyelitis optica, is one of my great passions. When I was in my neurology training, I knew that I was really drawn to the autoimmune inflammatory diseases of the nervous system, but I wasn't quite sure exactly what area of neurology I would specialize in. And when I did my training at the University of Pittsburgh in neurology, I had the opportunity to meet a young woman who had come in who unfortunately had been experiencing a lot of itching, burning sensations on her neck and her face and around her ear. And around the same time, she had actually developed hiccups. And she, didn't know what was going on, went to see her primary care doctor, and had been referred to so many specialists to figure out what was going on with these hiccups and why she was having this facial pain. And she ended up finally, when multiple gastroenterology or stomach workups for the hiccups were found to be unremarkable, she actually was ultimately referred to a neurologist who ordered a scan and found that she had a significant abnormality, not only going down into the spinal cord, but also going up into her brainstem. And so at that time, there was very little known about NMO, and she was actually told that she had a tumor in her brainstem. And so she was referred to the main hospital that I was working at as a neurology resident at that time when I met her. And fortunately, shortly before that time, the neurology community had become more aware of neuromyelitis optica spectrum disorders because the autoantibody, the aquaporin 4 IgG antibody that we use to test for this condition, had recently been discovered by Dr. Van de Lennen at the Mayo Clinic. And so, on when this really nice woman came into the hospital, we tested for that and actually found that she had that antibody. And so, luckily for her, the abnormality that we found on her MRI image was not cancer, it was actually inflammation related to NMO. And so, at the time I met her, there was not much known about effective treatments for NMO. And so she, she ultimately received plasmapheresis and got significantly better from that, but required a number of different treatments to alter her immune system to prevent recurrent attacks. And eventually, those became very well controlled. But this early experience with taking care of a young woman who, went from being told that she had cancer to then being told that she had neuromyelitis optica and that it was a disease that could be managed and that her symptoms could be treated was a really rewarding experience for me, and really hit home as to how important it is to make the right diagnosis for somebody as quickly as possible, and to make sure that our healthcare community and our doctors and nurses and nurse practitioners really know what this disease is and know to not delay time and to get people on the appropriate treatment. And so that actually meeting that woman and taking care of her and making that diagnosis for her is actually what led me into becoming a neuroimmunologist to begin with. And so again, I'm just so excited that the Sumaira Foundation has all kinds of opportunities to connect you with these resources. So, since completing my residency at the University of Pittsburgh, I returned to my hometown of Columbus, Ohio, and did a fellowship in multiple sclerosis and neuroimmunology at The Ohio State University. And I also completed my master's of public health there so that I could continue to do research. I served on faculty there for a couple of years and then moved over to Ohio Health, which is a very large neuroscience center within Columbus. And I'm really privileged to be able to work with several wonderful colleagues in my field. And we take care of collectively over 4,000 patients with various neuroimmune disorders, and certainly neuromyelitis optica. Spectrum disorders and similar disorders is something that we see a lot of and want to empower people to do the best. So I'd like to go ahead and just let you know a few things as we get started. So please feel free to ask me anything as the presentation is going along. I'm happy to answer any questions, and all questions are incredibly important. So again, I'm really pleased to be speaking on neuromyelitis optica, spectrum disorders, and cancer on behalf of the Sumaira Foundation for NMO from the Experts Facebook Live series. This programming is made possible thanks to a patient education grant from Viela Bio. And Viela Bio is dedicated to the development and commercialization of novel life-changing medicines for patients with a wide range of autoimmune severe inflammatory diseases. Our approach to drug discovery is aimed at providing targeted treatments for improved outcomes for thousands of patients who have few or no therapeutic options. So if you'd like additional information about Viela, you can visit vielabio.com. So again, here in Columbus, I serve as the system chief for neuroimmunology and MS at the Ohio Health Multiple Sclerosis Center, and run a fellowship program and do quite a bit of research. So again, I'd be really happy to answer any questions that you have. So as we get started, I'd like to just give you a little bit of an introduction about NMO spectrum disorders and cancer and what we know, because it's not something that's commonly talked about. So as you know, neuromyelitis optica traditionally occurs in the setting of somebody experiencing either optic neuritis or an inflammation of the optic nerve that can lead to vision changes and even blindness, as well as long spinal cord lesions or inflammation in the spinal cord, which can result in weakness, numbness, bowel and bladder dysfunction, walking difficulties, sexual dysfunction, you name it. And most commonly, when physicians hear about this condition, they think of it as being autoimmune, which is the most common cause of NMO, where our own immune system is actually targeting our own receptors in our body called aquaporin 4. And our white blood cells are producing antibodies that unfortunately bind to those receptors within our nervous system and result in inflammation and damage, which can cause the serious symptoms of neuromyelitis optica. So, today we're talking about cancer and NMO, and so that would be a very rare occurrence in the setting of neuromyelitis optica spectrum disorders. So there is something called perineoplastic neurologic disease, and what that means is that sometimes people can have a small cancer somewhere in their body where their own immune system actually recognizes that small cancer as being foreign, which is what our immune system is supposed to do. It's supposed to recognize foreign invaders like infections and viruses and get rid of them so that we're not sick forever, or that we don't succumb to those infections. And it's the same with cancer. When our own immune system recognizes a cancer as foreign, it builds up an immune response. And interestingly, sometimes that immune response, that cancer or that tumor tissue, can look very similar to the surface of that aquaporin 4 channel. And so that channel that's normally attacked by the antibodies that are made in our body in the setting of neuromyelitis optica. And so there are some individuals who would present in the same way that anybody would when they have NMO or NMO spectrum disorder, but that it's not just caused by our immune system alone, but it's actually the fact that there's a small cancer in our body and our immune system is reacting to that cancer, and the antibodies produced by our immune system against the cancer actually cross-react with the aquaporin 4 channels within our nervous system. And so it's very important that we're aware of that, because the treatment of that would be different from how we traditionally treat somebody with neuromyelitis optica spectrum disorder who does not have cancer. So in that setting, really the treatment is a connection between the neuroimmunologist working with the oncologist, specialist in cancer. Treating the cancer oftentimes, if we can cure that cancer or get rid of it, would result in a resolution of the neuromyelitis optica condition. And so treating the cancer results in the reduction of those autoantibodies and then prevention of future attacks. Now, that being said, a lot of people ask questions like, how common is this? Well, I'll tell you, it is not very common that this occurs. So when we look at research that mentions how prevalent is this, if we look at all the cases of individuals with NMO, there have been case series where where it said that the prevalence of this is like 0.02% within the population. So you can see that that is an incredibly low prevalence. And I'll tell you, as a neuroimmunologist who takes care of a lot of individuals with neuromyelitis optica, I only have a handful of patients who have had it in combination with cancer. The other important thing to know is that somebody could have neuromyelitis optica and then also have a separate cancer, and they could be completely unrelated. And so it's really important that we investigate and understand, is the cancer that occurred, around the same time as the onset of NMO, is that connected or is that separate? And so, the other thing is that obviously as humans, even though we may have a rare condition like NMO spectrum disorder, we could also develop cancer just like anybody else would be at risk for in their lifetime later on. And so if we've had NMO for some time and then down the road we develop cancer, we may still require the treatment for that autoimmune NMO condition, and in addition develop cancer later on that's unrelated and need treatment for that. Now, I wanted to share with you, how we would think about who might be at risk for this, because you may be saying, well, wait a minute, I have NMO and nobody ever told me about this, or nobody ever looked to see if I had cancer. And so really there are a couple of things that we've identified from research that if we see this, we should think about that and evaluate somebody to rule out a small cancer. So for instance, sometimes it's very clear cut where I've seen individuals where they've come in the hospital with significant, new weakness and numbness in their entire body, maybe from the shoulders down, and they're calling me as the neuroimmunologist to come help this patient. But at the same time, the patient mentions, I noticed that there was a mass in my breast in the past couple months, and I hadn't seen a doctor yet. And so that would be more of a clear-cut case where it's pretty easy to identify that there's likely some type of breast cancer going on, and this individual has presented with their first attack of NMO. And so we would certainly test them for the blood test for the NMO IGG, or the aquaporin 4 antibody that traditionally is tested for in the blood. We know that that could also be tested for in the spinal fluid, but that in combination with the appropriate imaging findings, would be diagnostic of NMO spectrum disorder. And then furthermore, we would need to work in collaboration with the oncologist to really treat that cancer, because in that case, we would certainly suspect that that was NMO as a result of breast cancer. Now, that being said, it may not be that clear cut. So somebody may come in with, let's say, new optic neuritis, and that optic neuritis was severe, and that individual received steroids, and then maybe they required plasmapheresis as well to have to stop the inflammatory process and to help to allow their optic neuritis to recover. But then that individual, we tested them, we identified in their blood that they had the NMO IGG antibody, that they were positive for that. We would want to know about that individual's lifestyle. So it's very important when you see your doctor that they understand, what are important risk factors that you may have for cancer. So when I'm meeting somebody, I'm always going to ask, are you a smoker, or do you have a history of tobacco use? We also want to know about your family history, because there may be other factors that play a role that we need to be more concerned for. Do you have a strong family history of cancer? And then we can utilize that to help to know, who maybe needs further workup to determine if cancer could possibly be a cause. So for instance, in the literature, it shows that people who come in who present with their first attack of NMO at an older age would be people who are more likely to have their NMO in connection with cancer. So for instance, traditionally, we normally see individuals with NMO presenting in their 40s, 30s. Certainly, it could be much younger than that. I've taken care of children with NMO, and it can be much later. But when we have somebody presenting in their elderly years, which I've seen people come in their 80s with their first attack of NMO where it's been connected to cancer, or even their 60s. That would be an older age of onset, and that would be somebody where we would want to make sure that we screened them for cancer. Now, there is not yet in the world of NMO a algorithm for how to work this up. And so for many doctors, it would be their clinical evaluation, their physical exam. But I would recommend that every single individual with NMO spectrum disorder get their age-appropriate cancer screening. Well, in fact, we'd recommend that for everybody, because that's going to be something that helps to monitor you and make sure that we've identified if there is any underlying cancer. So, for women, traditionally that's going to be, getting mammograms at an appropriate age, doing self-breast exams, making sure that you're following up for your PAP to make sure that there's not evidence of cervical cancer. For individuals who are smokers, making sure that you're following with your primary care doctor to monitor to see if there could be any signs of lung cancer. Certainly, if you are a smoker, we know that tobacco smoke is a significant risk for new inflammatory attacks, and it's also, we know it's harmful to your health from a standpoint of your heart and your cardiovascular system and your brain health. And so we would want to help you when you were motivated to help you to quit, because we want to minimize that risk. But in terms of looking for this, again, it is incredibly rare that we see what we call the connection or the trigger for the NMO to actually be a small cancer in the body. But we need to be aware of that, because if we miss that, even if we're putting somebody with NMO on a treatment to fight NMO, then we may actually not be helping them to the best of our ability, because we know that we have to care for that underlying cancer before their NMO can be controlled. Now, I wanted to share with you some common types of, or even though I've said this is a very uncommon connection, I want to share with you what cancers we have seen in connection with NMO. So probably the two most common cancers that we've seen are lung cancer and breast cancer. In lung and breast cancer, typically there's a type of cancer called adenocarcinoma, and that's what has most commonly been reported in connection with NMO when cancer is the underlying cause. Now, there have been many other types of cancer that have been reported. So for instance, in the medical literature, there have been people who've had stomach cancers. There's a type of stomach cancer called carcinoid. There is a type of small bowel cancer that has been reported. Um, there are people who have blood cancers. So there are B cell cancers. B cells are a type of white blood cell. That has been reported from people who have thymoma or other types of lymphoma. Thymomas are cancers of the thyroid. And then, as we mentioned, cervical cancer, and even cases of certain types of, there's something called leiomyosarcoma. So again, there are many different possibilities, and we just need to make sure that if you've presented at a later age or you have other risk factors for cancer, then we're making sure to rule that out. But again, most commonly, people are going to have NMO spectrum disorder related to autoimmunity and not due to cancer. And so, again, just to be clear, NMO can happen independent of cancer. So someone could have NMO from the autoimmune disease NMO and also have a separate cancer, or they could have cancer, which then triggers NMO to onset. And so that is something that there is a lot of research being done on, and certainly we have a long way to go with learning more about that. Now, in terms of, there are so many great questions that I'm seeing pop up here in the chat, and I want to start to address some of these. So, do you have statistics about MOG and cancer? And so MOG, as many of you know, is a entity that has been more newly recognized, even more newly recognized than NMO, and is obviously starting to finally get the attention that it deserves, and the research so that we fully understand this. And I'll tell you that there is not much known about MOG and cancer. Certainly we know that, with neurological diseases, we can see these autoantibodies being triggered from a small cancer. So I wouldn't be surprised if over time we see more and more of this, that there are cases of perineoplastic MOG. I'll tell you, in my clinical experience, I have not seen the perineoplastic version of MOG occur. But it would not be unheard of. One of the interesting things that reminds me of that I wanted to mention is when we look at individuals who have NMO, which is triggered by cancer, in the studies, it actually shows that tends to be more common in men. And we know that in NMO spectrum disorders, when we look at the how common it is in women versus men, we know that it is much, much more common in women as compared to men. So it's a predominance of about 9-1. When we look at MOG, we don't see that separation is as big as it is with NMO. Another question that was mentioned here is how frequently does the NMO or the MOG diagnosis come before the cancer diagnosis and vice versa? And I think that is a wonderful question. And I would say that, it is very interesting, but I will tell you that the number of times that I've seen it has typically been, I've seen both cases occur, and I don't think that anybody has officially done a study to show, how that's happened in the timeline of the diagnosis of NMO versus the cancer diagnosis. But when researchers have looked at this, what they've classified as NMO in connection with cancer has really been, they've looked at folks who've been diagnosed with both diagnoses within 2 years of each other. And so, again, I don't have a good answer for that, but I would say that, it would probably depend on what the person experienced first. And in the majority of the cases that I have seen, I've kind of seen 50-50 of, again, it's not a common thing, but seen just like the patient I shared with you who came in who had just noticed a breast mass and had a transverse myelitis and had the NMO antibody. That was pretty much at the same time within a couple of months, but she had not been evaluated for either. She sought medical attention at the time of developing the transverse myelitis or the spinal cord inflammation and weakness. But certainly we know that people that have cancer that's known can go on later to develop neurologic symptoms. And I have seen unfortunate individuals who've had cancer for some time who then have developed neurological symptoms concerning for NMO, where then they did have the autoantibody, and that was cancer diagnosis first. And so I think we need to know that it can happen either way. Thank you also for the excellent question about what are the most common types of cancer related to NMO and MOG. Again, really the most common are breast cancer and lung cancer. And so we know that, again, with NMO, we discussed that this disease is much more prevalent in women. And so it's not surprising to see that breast cancer is one of the more common types of cancer that we can see this combination occur with, because we know that for women, unfortunately, breast cancer is fairly common. So we know that 1 in 9 women is affected by breast cancer in her lifetime. And again, with the lung cancer, we know that lung cancer can occur even in individuals who don't smoke tobacco or use tobacco products, but we do know that that association tends to be more common. So again, making sure that we're minimizing those health risks and, if we can, working to quit smoking. So another great question in here is, are there differences in the frequencies and or types of cancers for aquaporin 4 positive versus MOG positive individuals? And I think that that is an excellent question. What I can tell you is, because we haven't had as much time to study individuals with MOG who develop cancer as we have with NMO, and this is still a relatively uncommon scenario, we really don't have any good data to say that the types of cancers associated with MOG would be different than the types of cancers associated with NMO. But just like we see very distinct differences between the two conditions and how the two conditions are treated, I would suspect that there may be some differences there. But again, there's not enough information at the present time to really be able to define different cancers associated with each autoantibody. Here is another excellent question. So, does a diagnosis of interstitial lung disease increase the chance of lung cancer in a child? I am a neurologist and neuroimmunologist, and so I'm certainly not an oncologist or an expert in interstitial lung disease or lung cancer. So I'll ask you to ask an oncologist that question, because again, that's just not my area of expertise. So we'll go ahead and move to the next question. So in terms of, please discuss the implications of being on rituximab. Are there any specific additional considerations or testing one should undertake? That's a great question. So as many of you know, rituximab is a very common treatment that can be used for NMO spectrum disorders. It is sometimes used in MOG as well, although we find that it appears to be much more effective for NMO spectrum disorders. So rituximab is an infusion treatment, so an IV medication that's been around for a long time, and it was originally FDA approved for other autoimmune diseases like lupus and rheumatoid arthritis. And what this treatment does is it actually it is an antibody itself that binds to a specific receptor on B cells, which are a type of white blood cell in our body. And when it binds to those B cells, it actually destroys them. And we found that that mechanism of getting rid of B cells, which are predominantly our antibody producing cells, is very, very effective in treating certain autoimmune diseases. And particularly in NMO, where we know that that autoantibody, that NMO IgG that binds to aquaporin 4 receptors, or the water channels in our body, is really what's triggering the inflammatory attack and then causes the significant destruction within our optic nerves, our spinal cord, or certainly our brainstem and other areas that can be affected by NMO. So rituximab has been shown to be very effective, and that's actually still the most common treatment that is used for neuromyelitis optica spectrum disorders, even though we've had other therapies that finally have been FDA approved for NMO spectrum disorder. So when we talk about any specific considerations or testing one should undertake with this treatment, in general, before starting it, we want to make sure that we have a good look at somebody's blood counts. So we check something called a CBC with differential. We want to make sure that somebody has a good liver, that their liver functions look good, because this medicine is broken down by the liver. And then we also want to make sure that we know about that specific individual's infection history. If somebody is having frequent infections or frequent urinary tract infections, upper respiratory infections, that would be a concern, because rituximab does slightly increase that risk. And so we want to make sure this is an appropriate treatment for that individual, or that we at least address what the underlying issue is. Maybe that person needs to be seen by a urologist or a bladder specialist to be able to better manage the bladder, to reduce the chance that they're going to have recurrent infections. The other thing that we check before we start rituximab or similar therapies that deplete B cells is something called immunoglobulins. So that's a fancy word that basically means we're looking to see what your antibodies response looks like. So in our bodies, we have antibody responses that help us to respond to infections that we've seen before and infections that our body has never seen before. And so looking at those levels at baseline can be very helpful to know before you start rituximab where you're starting from. And then over time, we want to monitor those, because that helps us to know who might be more at risk for infection. And there have been a lot of studies looking at this, particularly throughout Europe, that have shown that if people have really low levels of their immunoglobulins or their antibodies, particularly IgG, they would be more at risk for frequent infection. So that's something that we as physicians and the medical experts want to test, so that we can keep you safe, so that we're effectively treating your NMO, but we're preventing those risks. And then over time, the other thing that we check is to make sure that those B cells, the cells that we're trying to suppress, the ones that are producing those antibodies that lead to the destruction within your nervous system, that they are suppressed. And so we can check a blood test to look at those B cell counts. It can be called different things, but typically it's called a CD19 count, because CD19 is another receptor that's also present on white blood cells, where that CD20 receptor is, and that's where the rituximab binds and leads to destruction. So when somebody's on rituximab, we would expect when we check that is going to be 0, that we can't detect any of those cells within your system. If somebody's getting rituximab every 6 months, but we find that at 5 months, those B cells are coming back earlier, that would be concerning, because that could leave you open to having a new relapse or a new attack. And so some individuals may need to receive rituximab every 5 months or even every 4 months. And so that's something that your doctor is going to monitor over time and make sure that your B cells are being adequately suppressed on the rituximab. And then just the last thing that I would mention for that question is that before starting rituximab, we want to make sure that somebody doesn't have tuberculosis or a viral hepatitis or HIV, because we would not want to put somebody on that medication if they had those serious infections, because that could make those infection worse. And so we're always going to be careful about making sure that's not the case prior to starting. Now, there's another question here. How does treatment differ for those who have cancer with NMO? I have recurrent thyroid cancer with MOG. I am currently on tocilizumab monthly. Yes, so that's another wonderful question. Gosh, you guys have so many great questions today. So again, it's going to depend on the particular individual. So for instance, if somebody has an underlying cancer that they are found to have in combination with NMO, at the time of diagnosis or after being on treatment for a while, your doctor may decide that the resection of that tumor potentially, or the chemotherapy used to treat that cancer, that may be the treatment that works for both the cancer and the NMO. Now, there may be cases, again, where even though somebody has cancer, that their NMO is not caused by that cancer. And so there may be scenarios where individuals have to be treated for the cancer specifically, which, again, depending on the type of cancer, can differ significantly, whether that is a chemo or whether that is resection of a tumor and radiation, or whether it is, there are many treatments that are hormonal therapies or other immunotherapies to alter that cancer's ability to grow and spread in the body. And so, just as in the case of this patient who has mentioned this question here, she's on a treatment called tocilizumab. And tocilizumab is an anti-IL-6. It's an IV infusion, and that really works to target the immune system and can be an incredibly effective treatment. We have found for MOG. We know there's no FDA-approved treatments for MOG, but again, some individuals, there may be a separate treatment for their cancer from the underlying autoimmune disease. But I think in cases where we know that they're connected, oftentimes it's treating the cancer will be effective at preventing recurrent attacks. Now, there's another question here. If you have double negative NMO, is it more likely that it is triggered by cancer? And so in this instance, this means if I've had attacks of either optic neuritis or long transverse myelitis, or maybe I've had an attack in my brainstem called the area postrema syndrome, where I had nausea and vomiting or hiccups that didn't go away for a very long time, and my doctors have been very suspicious of neuromyelitis optica or very suspicious of MOG based on how that individual presented, but they tested the blood test and they're both negative, or maybe they even did spinal fluid and they're negative for those antibodies. Does that mean I'm more likely to have cancer? And the answer is no, not necessarily. We know that, it's important to know that early on, when you are originally diagnosed, it's possible that you might test negative for these antibodies. And you may find that over time, that your doctor wants to retest for these autoantibodies. And many of us in the field have found that it may be important to repeat these tests, maybe on a basis of every 6 months for a couple years, to truly determine if somebody's truly NMO negative or MOG negative. And then we also know that just like we didn't know for a very long time that MOG was often very commonly the cause of the inflammatory attacks for people who appeared to have NMO spectrum disorders, but actually were later found to have that MOG antibody positive, that there are likely many other autoantibodies that we don't know about yet. And so I suspect that if we have the same talk a couple years from now, we'll probably be talking about other antibodies that are available that we just haven't discovered. And I think the other challenge too is that we know that time is of the essence when you come in with this condition. And so if you're having an attack, you might be somebody who the neurologist that you see starts treating you right away with steroids, or they start plasmapheresis and then they realize, oh no, we didn't send that blood test, and they try to send it after you've already received that treatment or you're into the course of that treatment. That antibody test may be negative because we treated you, and you may be started on a long-term treatment to prevent recurrent attacks, and so it may be harder to detect that antibody. So I think certainly it's it's definitely a possibility. We don't want to ignore the fact that that's sure, could what happened be from a small underlying cancer? Maybe. And so we want to make sure we screen for that. And so your doctor may do age appropriate cancer screening. They may say, you know what, I want to check and do a CT scan of the chest and the abdomen and the pelvis to make sure there's not any kind of solid organ tumor. Or there's even another condition called neurosarcoidosis or sarcoid, where we can sometimes find these firm tissues called granulomas in the lungs that could sometimes also mimic NMO or MOG. And so definitely we want to do an expansive workup, but again, I would be careful to say that it doesn't mean that it's more likely triggered by cancer. It's just one of many possibilities. So I have another question here, and it says, "Hi doc, I would like to know how common it is for a patient to have cancer and only present the aquaporin 4 antibodies within that cancerous tumor." So, I think that in terms of someone to come in with cancer, we know that, we can produce aquaporin 4 antibodies in the immune system in response to a small cancer. But if those antibodies are produced, oftentimes, those would hit the other receptors, the water channels or the aquaporin 4 receptors within our body, and could lead to these inflammatory attacks. I think that the question is a good one, though, because, traditionally when somebody develops a cancer, oncologist, if that individual is not presenting with any neurological symptoms, an oncologist is not going to test for aquaporin 4 IgG or the NMO IgG, and they're not going to test for MOG because these are tests that are traditionally done by neurologists when you present with neurological symptoms. And so, could people have those antibodies in the setting of having a cancer and not present with neurological symptoms? It's certainly possible, but I would say because they're just really not tested unless people have neurological symptoms, I think that it would be really hard to know, if somebody produces those antibodies, how often that happens without neurological symptoms. But I think, traditionally when we see that antibody and we see that in combination with the neurological symptoms, we know that we need to address that promptly. So there's another question here. Do you think that rituximab might cause a CLL diagnosis, so chronic lymphocytic leukemia? We know that with our treatments for these diseases, that our treatments potentially could cause other medical problems. And when we alter the immune system, we know that there could be rare risks of cancer that occur in combination with that. Now, that would be incredibly rare. We know that rituximab, again, has been a treatment that's been around for a very long time. It's something that is very effective and can be very safe when monitored by a specialist with significant experience. And it's something that, we consider it to be safe enough that we often use it in children who have NMO spectrum disorders or other inflammatory neurologic disorders. And so, again, I would say that yes, we could use a treatment like rituximab, and that could potentially trigger a blood cancer, but that would be incredibly rare. And that's why it's important over time that when you're on these types of treatments, that's why your doctor wants to monitor you with regular blood work. For the most part, that can be fairly easy to get because we can connect it with being drawn at the time that you're doing your infusion. And so that's why we're going to want to monitor your blood counts and your liver functions and all of that, just to make sure that there's nothing else, that's happening as a result of being on treatment. But again, I can tell you that I, fortunately, knock on wood, have never had a patient develop a blood cancer from being on rituximab. So the next question is, what steps or actions should someone on rituximab take if they have low IgG levels? example, 644 for IgG, 36 for IgM, and 53 for IgA to boost IgG levels. Well, so, it's interesting. This has been a big debate within the neurologist community, and especially among NMO experts and MS experts, because there are a lot of different B-cell depletion therapies that we use now. And so, one of the things that we found is that in terms of the immunoglobulins, it tends to be the IgG that is associated. If that's low, that's associated with the biggest risk of having recurrent infections. Now, it's very interesting that some people can have low IgG levels and they're not getting any infections. So, a lot of it is not looking at an absolute level of immunoglobulins, but it's looking at the individual and seeing, okay, this person may have a slightly low IgG, they might be 500 or 490, but they're not having any infections, and I'm going to monitor them closely, and we're going to watch that. And so, there's not an absolute where we say, at this IgG level, that's it. Now, that being said, we tend to get more concerned when that IgG level drops below 500, because, again, that's where we tend to see a higher risk of infection. So for the individual that's asking this question, in IgG of 644, I wouldn't really be super alarmed. Commonly, when people are on rituximab or other B-cell depletion therapies, I do see that IgM going low, but I'll tell you that's really of the lowest, not of great concern, because yes, could IgM being low slightly increase the risk of infection? Yes, but it's not to the same degree of IgG. And so, there are some individuals where, they may need this treatment. They may really need rituximab, and they have low immunoglobulins, and they may need to receive a treatment called IVIG, or IV immunoglobulin, where they actually receive an infusion to raise their immunoglobulins. There are treatments as well. There is subcutaneous injections of immunoglobulin that can be given as well. And so for people who need to stay on a treatment but are having infections because of low immunoglobulins, they may actually receive that as a supplement. Outside of receiving that as a supplement or actually stopping the medication that's triggering the low immunoglobulins, there's not really anything else supplement-wise or behavior lifestyle-wise that's been shown to boost immunoglobulin levels. So here's another question. In my case, I had my first NMO attack and then was only diagnosed with a perineoplastic thyroid cancer months later. The tumor contained aquaporin 4 cells and was removed. I was then treated with rituximab and then left off any preventative for almost a year before I then relapsed with another NMO attack. So thank you so much for sharing your experience, because that's really important to share and say that, they really thought that I had NMO related to a cancer, but even when the cancer was removed and treated, I had another NMO attack. And so I think that that's a really important experience to share, because we don't want in medicine to falsely assume that because somebody's cancer has been treated and that it's gone, that we're done, that NMO can't cause further problems. I think one of the ways that we can monitor for that, because it can be a challenge to know that, and I think that most individuals and most professionals in the healthcare field would not want to commit somebody to long-term immune suppression unless they knew that that person really needed it. And so in terms of how we would monitor, I think that most neuroimmunologists would recommend that they repeat that antibody test over time. And if the antibody test was still positive or present in the blood, even with the cancer removed, then that would signify to me that there's still a concern there and there's still repeat inflammatory attacks that could occur. And so I think it's a really good example of how, it may not be as clear cut that it's just a perineoplastic NMO, and that it could certainly be somebody who has NMO spectrum disorder who just happened to have a cancer noticed at the same time. And so, that can be really complicated, but I think it's important to know that even if you were diagnosed and it was believed to be due to a cancer, even if the cancer is gone, we still need to monitor you very closely, and make sure that we're protecting you. And I'm really sorry that that happened to you. There's another question here. Some of my daughter's symptoms can also be related to her other conditions, but she started with optic neuritis and extreme fatigue at the end of 2019. What can they do to rule out DEVIX, which again is sort of the old name for neuromyelitis optica? I have a telephone consultation next week. Is there anything I can ask to be done? That's a great question. So in terms of what can be done, the good news is that you have the opportunity to advocate, and you're right. If somebody had optic neuritis, in my opinion, I think that even though NMO is not the most common cause of optic neuritis, I think that we need to think about it. We also need to think about MOG. And so, in my practice as a neuroimmunologist, for anybody who's had optic neuritis, I'm evaluating them with a number of blood tests to look to see if we can find the cause of that optic neuritis. Sometimes optic neuritis could be due to NMO or MOG. It could also be due to multiple sclerosis. It could also be due to infection, or Lyme disease, or a number of other things going on. And so there is a series of blood tests that would be important and recommended to rule out vitamin deficiencies, infections, and autoimmune conditions. The other thing that's really important is if somebody's had optic neuritis, I would also recommend that they have an MRI of their brain and their spine. Because if we see that they've had optic neuritis, and then we also look and we see other lesions, we might see areas of inflammation that look like somebody has multiple sclerosis, because maybe they have spots that are out near the cortex of the brain, or the connecting part of the brain, the corpus callosum, the brainstem, or the spinal cord, that look like MS. And so that would be really helpful, because we may then be able to know why your daughter had optic neuritis and help her to prevent her from having new damage moving forward. The other thing is, when we look at optic neuritis, it actually matters how significant that optic neuritis was. So for some people, they may have received steroids and had near complete recovery, done very well. That might suggest that maybe it's less likely to be an NMO optic neuritis, because that tends to be a lot more destructive. It doesn't rule it out, but it might provide some content there. We can also do a test called an OCT, where the individual who's had optic neuritis looks into a machine, and it measures the thickness of the optic nerve, and it's called the retinal nerve fiber layer. And when we look at that thickness, the pattern of how the damage occurred, or where the damage occurred, can be helpful. If we see that it spans across the entire optic nerve, then that can be more commonly what we see in NMO type optic neuritis. Versus in MS type optic neuritis, we might just see a thinning more in the temporal portion of the optic nerve, or more out towards your temple. In addition, if we get a look on the MRI, if we're looking specifically at the orbits and we can look at that optic nerve, we can see, was that optic neuritis a long optic neuritis? Because just like in NMO or MOG, we can see those long areas of inflammation in the spinal cord, where we call it longitudinally extensive transverse myelitis. We can see in optic neuritis in NMO that people can have what we call longitudinally extensive transverse myelitis. And so what I would ask when you see the specialist is, what can we do to try to find out an answer as to what caused the optic neuritis, make sure that the blood tests are done, and I would also make sure that there's an MRI, and it can also be helpful either if that specialist has the ability to do an OCT, or if your daughter needs to be seen by a neuro-ophthalmologist to evaluate for the degree of damage and to better understand the impact on the optic nerve. That can all be very helpful. Sometimes, depending on the situation, spinal fluid testing may also be helpful, so a spinal tap. But again, I would encourage you to talk to her doctor about that, and I wish you all the best, and I hope you get some good answers soon. Okay, so we are about a few minutes left here. I'd be happy to take any more questions, so if anybody has anything they want to throw in real quick, I'd be happy to answer that. And if not, I hope that you all, have a great 2021. Hopefully, being safe. And I think one other thing that I wanted to mention is that I've had a lot of questions about from my patients for people who have NMO and worried about protecting themselves from the coronavirus. And so definitely talk with your doctor and make sure that you talk with them about the vaccines. The vaccines, we have seen that those appear to be safe for individuals with NMO and MOG. Again, we don't have extensive studies specifically in people who have these conditions, but we know that the vaccines, at least the ones that are the RNA vaccines, that those are not live vaccines, and we are recommending those to all of our patients. But I encourage you to talk to your doctor about the right timing of when to get the vaccine, because it may depend on the treatment that you're taking as to when you should receive it. And then looks like last question here, my daughter has thymic, hyperplasia, and MOG. Doctors suggest thymectomy to possibly help with MOG. Yeah, so it sounds like there's a concern that potentially the abnormal thymus could be triggering this inflammation. I would talk to your doctors about the potential risks and benefits, and it is certainly possible that removing that could result in appropriate resolution of the MOG, but I think it's not an absolute. So make sure that you feel comfortable with the risks and benefits of doing that. And I, would encourage you to get lots of opinions about that. So again, I appreciate all of you. Thank you so much for joining, and please give us any feedback you have, and I hope that you all have a wonderful rest of the day, and take care.